starring my beautiful ambulance.
Hi, friends, Romans, countrymen. I'm Alice Hoyt, and I decided to do my video about pulmonary edema or congestive heart failure. So, the pathophysiology, really, there's two kinds of pulmonary edema. There's non-cardiogenic, so not heart-related, and then cardiogenic. First, with the non-cardiogenic, it's going to be basically anything that's not caused by heart failure specifically. So it's damage to the alveoli and the capillaries, the smaller airways. That could be from hypoxemia or a O2 deficiency in the blood, arterial blood. That can come from near drowning, toxic inhalation, drugs, alcohol abuse, also high altitudes, and basically what that does, it again damages the smaller airways, forcing fluid into those airways, and it's going to fill up, cause pulmonary edema. So that's why it's called high permeability. This actually can lead to the development of acute respiratory distress syndrome. Now, cardiogenic pulmonary edema caused by heart failure is more due to damage to the heart. So the heart itself is weakened. It could be enlarged in an unhealthy sense. This basically means that the heart can't pump adequate blood volume to the rest of the body. So that's, cardiomyopathy, previous heart attack, AFib or other arrhythmias. Anything like that that's caused damage to the heart muscle can lead to heart failure. And basically what this does to the body, there's two types. Again, there's right-sided and left-sided. So your left-sided heart failure means the left ventricle is not adequately pumping blood to the rest of the body, because again, your left ventricle, that's your it pumps to the rest of the system. So basically what that does, it's not moving enough volume out of the heart, and the pulmonary vessels get backed up with this extra fluid that doesn't have anywhere to go. And so it's forced into the lungs, again, filling around the alveoli, the smaller airways, the lung parenchyma. And so you're gonna end up with pulmonary edema and difficulty breathing as a result. Now, the right-sided heart failure, your right ventricle is not pumping adequate volume, and the problem here is that you're not getting the volume you need to the pulmonary vessels, so it's backing up into your veins. This is going to cause your peripheral edema, your legs and feet especially. This is where you get the really obvious CHF patients who have severe edema. So on top of all this, your heart's not doing great in the first place. Your body over time is going to start releasing stress hormones to make your heart beat faster and stronger, which unfortunately ends up damaging it even more in the long run. You get your thickened ventricles, which can no longer hold as much volume. So kind of a bad chain reaction, because the kidneys don't receive enough blood. They start malfunctioning, and then you're not getting rid of your excess fluid. So that's just a whole bad situation. So as far as assessing your patients here, a lot of this, it's really more focused on shortness of breath due to pulmonary edema. So you're going to do your regular assessment, but you're going to watch for swelling or edema in the legs, the abdomen, persistent cough, shortness of breath doing normal activities or even lying down, because again, that fluid in the lungs is surrounding the alveoli, so especially lying down is going to cause problems. When they're sitting up, gravity kind of takes over and it might draw away from the alveoli a little bit. They're also more likely to get lightheaded and fatigued doing normal tasks, be a little bit confused about low oxygen. They may be tachycardic. They may have some nausea, loss of appetite. Now, you want to listen to your lung sounds. Make sure you listen in upper and lower fields bilaterally, because You may get crackles in the lower fields indicating some edema, pulmonary edema, but if it's up in your higher fields, up near the apexes of the lungs, that indicates a really severe problem. You're gonna have some fluid basically filling up the airways and they can't breathe. If it's very, very severe, you're gonna get your patient's gonna be coughing up sputum, watery, frothy, pink sputum. That's a really bad sign. Okay, so with CHF specifically, you're wanting to reduce the workload of the heart because again, it's not functioning well. It's fighting really hard, but it's just not moving that blood volume. So you're going to achieve this with vasodilators is one way. So if you administer vasodilators like ACE inhibitors, angiotensin receptor blockers, or beta blockers, all of those are going to cause vasodilation. You also want to monitor for hypotension because again, if you're giving your vasodilators, you can actually go a little bit too far the other way. You're trying to reduce the blood pressure, but you don't want to go too far. Okay, so I'm going to talk about treatment as well. So what you're going to do, first of all, place the patient in a position of comfort, usually sitting up pretty high so that the fluid is going to the lower parts of the lungs and away from the alveoli. You're also going to want to start your supplemental O2. Got a non-rebreather here while you're setting up your other things, making sure they're getting as much oxygen as possible. I would, again, place them on end-tidal, monitor SpO2 to see if the oxygenation is effective at all. Then I'd go ahead and administer some nitro. So this is going to open up my patient's vessels and give the fluid somewhere to go. At least our protocol recommends giving 1.2 of nitro sublingual. So these are sublingual tablets. And then I would go ahead and start a CPAP. So this is going to, once I've actually opened up the vessels, I'm going to use a CPAP to push air into the lungs and force that fluid away from my alveoli so my patient can breathe and gas exchange can take place. So once I've done CPAP, I'm going to monitor. It's kind of controversial. My county protocol still says to give Lasix or a diuretic, and that's going to remove the excess fluid that you're pushing away and into the vessels. I know we talked in class about how that isn't necessarily indicated anymore. There is a danger with using diuretics because you can wash out the patient's electrolytes as well. And if you go too low or too high on specifically potassium, you're going to cause arrhythmias, and that's going to cause even more heart damage. So in the long run, you might be doing more damage in that case. Now, your patient may have been prescribed Lasix, in which case it's good to make sure you ask if they're taking their regular medication. It's usually a good indicator too if they're on dialysis or have some type of kidney failure or kidney problems that may be in conjunction with your heart failure, because again, not getting enough blood